Did your doctor just tell you that your uterus is falling? Well, you don't need to suffer. I'm going to give you options in this video about how to fix that problem. I am Jeff McQueary, a Tennessee urogynecologist. If your prolapse and incontinence problems are dominating your life, take back control by solving your problems with solutions from my channel, Women's Healthcare Answers. Well, technically, when the upper vagina or uterus is falling, it's called apical prolapse. What we're going to talk about today, though, is the uterus falling, and that's called uterine prolapse, and how that might be repaired so that you don't have this problem again. And stay till the end so that I can help you understand the specific procedures that might work for you. You can take that information to your doctor and make great decisions about your own pelvic health. There are more than 200,000 surgeries every year for pelvic prolapse, and often uterine prolapse and bladder prolapse kind of go together. In fact, it's not uncommon to have some sort of that uterine prolapse problem that may be unrecognized, and your doctor needs to be able to recognize this and fix all of your prolapse at the time of surgery, and certainly must have a plan of what to do if they see that at the time. When you are diagnosed with uterine prolapse by your gynecologist, the very first thing they may actually offer you is a hysterectomy. Especially if you're older and in poor health, that may very well not be what you want to do. But often surgeons don't do any pelvic repairs unless they do a hysterectomy. The problem is sometimes they do a hysterectomy and nothing else, and they don't suspend the upper vagina. I want to tell you that it doesn't have to be that way. Being able to preserve your uterus and still fix your prolapse has many positive benefits. In fact, in a recent study, up to 60% of women indicated that they would prefer to preserve their uterus and not have a hysterectomy if there were equal results from the surgical repair. Now, I think you would admit if there were reasons to remove your uterus other than prolapse, that you would do that. I always look for those reasons, and some of those reasons would be undiagnosed abnormal uterine bleeding. It could include abnormalities of the cervix and uterus, including even cancer. And sometimes cancers can even be hidden. So ultrasound prior to leaving the uterus in, I feel, is very important. You may also have had abnormal pap smears and have HPV. Certainly that could be a reason for just removal of the uterus and cervix, so that is less of a problem for you in the future. But an ultrasound also could detect any abnormalities of the ovaries and also be a reason for getting the uterus and ovaries out. Now, it is important that if you do maintain your uterus, cervix, and ovaries, that continued surveillance of that may be necessary with ultrasounds or pap smears, and that certainly would be appropriate. But if you've never had any abnormal pap smears, no abnormal bleeding, and your ultrasound is normal, then you honestly may have no reason to remove your uterus just because it's falling. Because it's the ligaments that are failing in that situation. Just so you understand that it simply has been the way doctors have treated uterine prolapse. They do a hysterectomy. It's really not a whole lot of evidence, though, even in the medical literature, to support that practice of hysterectomy. Now, a lot of things need to be taken into consideration as well, especially if you have multiple other prolapse issues. And ultimately, if you don't have your uterus removed, there is going to be considerations on how that surgery needs to be done. There are also different approaches, including vaginal, laparoscopic, robotically assisted laparoscopic, and even an abdominal incision can be done. There are other considerations, including using mesh, using other permanent materials, or just using your native tissues, which is the vaginal tissues God gave you. I think one of the main advantages over all surgeries is that not doing a hysterectomy is typically a shorter and easier surgery to recover from. You're under anesthesia for a shorter period of time, and if you don't remove the uterus versus a hysterectomy. So I guess what I'm saying is you do have a choice to make, and that choice is based upon the present and possible future abnormalities of the uterus, ovaries, and cervix. You might have to have surgery on your uterus or ovaries in the future. I will tell you that I just don't really consider this to be too relevant because the main reason that we remove the uterus and the ovaries is to avoid uterine and ovarian cancer. So if you don't have cancer in any of your glands in the body, do you just remove them just in case? So obviously the answer is no, so I don't always use that as a criteria of whether I'm going to remove the uterus. If everything looks normal by ultrasound, if you've never had any abnormalities, then again, the likelihood of cancer is low. So if you like this video so far, hit the like button. It really helps with YouTube, and please subscribe, because if you miss any of my videos, who am I going to talk to? So just give me a thumbs up and please comment because I want to help answer your questions. So what really are your surgical options? Well, your first option, and we talked about this before, is a hysterectomy. And this typically is accompanied by a resuspension of the upper vagina to the natural ligaments called the uterosacral ligaments. The actual name of that surgery is a hysterectomy, and that can be done laparoscopic or vaginal, and with a bilateral, that means both sides, uterosacral ligament colpopexy. So let me put that together again for you. The surgery can be done either vaginally or through the abdomen using a lighted scope or through an incision. There is even a newer procedure where we can do this surgery vaginally using lighted scopes. So this is called a V-Notes procedure. But still, few physicians are doing this this procedure at this time, and I'm one of those surgeons that does that procedure. So after the uterus has been removed, those stretched and torn ligaments can be reattached closer to the tailbone. So there is a new suspension of that upper vagina to the same ligaments. Those ligaments tend to be stronger and a little bit more fanned out as you get closer to the tailbone, which is called the sacrum. Now, the success rate for this surgery can be high, resulting in over a 90% success over many years. So you may want to choose this type of surgery if you do want to get rid of the uterus and ovaries. But a second option is sacral colpopexy or hysteropexy. This procedure uses mesh to either suspend the upper vagina or the uterus, and that is really the topic of this video. So if you want to avoid mesh, you won't want this procedure, but the success of this procedure is very high, well into the 95% range. There have been a lot of negatives in the news media about mesh, but most of that was mesh that was placed through the vagina, under the bladder, or over the rectal area. So the FDA did find concerns with vaginally placed mesh, but just so you know, it's mostly because of lack of superiority. That means it just wasn't better than normal tissue repairs. Now that was over a short period of time. I will admit that the mesh surgeries that I did, which have been long-lasting and successful, and I saw very little concern. But we unfortunately no longer have that option in the U.S. So the type of surgery we're talking about here is using a mesh in the abdominal cavity under the abdominal lining tissues called the peritoneum. That mesh is then connected to a ligament that goes along the tailbone. It's very successful and a strong procedure, and you should consider this procedure if your doctor does that procedure well or your prolapse is more severe, because it is a successful procedure in those situations. But a third option is what I do most. This is the attachment of the cervix to the sacrospinous ligament. This is a ligament deep in the pelvis and is a stabilizing ligament between the tailbone and your pelvic bones. We all have these ligaments on each side of our pelvis, both male and female. These tend to be very strong ligaments and are a good site to be able to reattach the uterus and to accomplish a very short surgery. It is common that if I find you have just uterine prolapse and I have to do nothing else, I can repair that prolapse in about 35 minutes. So that is a very short time under anesthesia, and yet success rates are about 94% plus. My own data says I have about a 98% success rate. The thing I like about this surgery is that you can get back to normal very quickly. So technically this is called a sacrospinous ligament hysterectomy. And that is suspension of the uterus and cervix to that ligament. So there's several techniques. One uses sutures, which are permanent or absorbable, and that connects to the side of the cervix to that ligament. The way I do it utilizes an anchoring system called Interstitial. This works extremely well, and these anchors push into the ligament and heal there permanently in that ligament. They have a non-absorbable suture that inserts through an eyelet and can be attached to the cervix, which is also strong tissue. So now you're connecting strong ligament tissue to strong cervical tissue, producing a much greater chance of success. When I attach vaginal tissues to that ligament, the risk for failure is certainly higher, but it's still not bad. So if the uterus doesn't need to be removed, this is the procedure that I do many times a week. So to sum all this up, you really have three options. If your uterus is falling, you can choose to have a hysterectomy and a uterosacral ligament colpopexy. You can have a mesh suspension of the uterus or upper vagina to the tailbone, and this is called a sacral colpopexy or a sacral hysterectomy if the uterus is still in. Or your last option, which is my favorite, that is a minimally invasive and works extremely well, is a vaginally placed sacrospinous ligament hysterectomy. So we're suspending the upper vagina and the uterus and the cervix to that ligament, and that's using the Interstitial system. But number one, talk to your doctor about your uterine prolapse, and now that you're armed with a lot of good information, ask what they do best. If you're not satisfied with the options that they give you, you can try to find another doctor, but you want to do the surgery that your doctor does best for the best outcome for you. So hopefully you feel you learned something. And as always, I've enjoyed being here with you. Please comment and like this video because I would love to continue to help solve your problems at Women's Healthcare Answers. And remember, this video is meant for information purposes only. Please consult your own healthcare provider, but it's okay to reference the information I give you.